Okay, so in this video we're going to talk about Chapter 18, disorders of blood flow and blood pressure. So we're going to first start out talking about the structure of a typical blood vessel. So the larger blood vessels of your body have three main layers here. We have our tunics, then we have tunica externa, tunica media, and tunica intima. Tunica externa is an outer layer made of collagen fibers. Think of this as being like the tough outer coating of a blood vessel. Tunica media is the smooth muscle and elastin layer. So this is going to be involved with regulating vessel diameter as well as elastic recoil. And then tunica intima, which is the deepest of those, and it's right adjacent to the lumen or space. It's going to be made of a simple squamous endothelium. So it's basically like an epithelium that lines the inside of blood vessels. So looking at the general structure of an artery or vein, we're going to find then we have our tunica externa. So it's a thick layer of collagen here. Tunica media is in the middle. It's a smooth muscle and elastin layer. And then we have tunica intima, where we have essentially our lumen, but our endothelial cells that line that lumen, and then an underlying connective tissue membrane. Now, veins are typically wider than arteries because their walls are thinner. Arteries also typically have thicker walls because they need to resist more pressure, because technically an artery is what carries blood away from the heart. So this question here says, which vessel layer can expand and accommodate pressure changes? Well, we know that's tunica media, right? Because tunica media has a lot of elastic fibers within it, and it has a smooth muscle which can change its diameter to help regulate resistance and blood pressure accordingly. So in terms of the endothelium that lines the inside of our blood vessels, we find then that it allows for food and O2 to pass into tissues from blood. Because it's a thin layer of simple squamous cells, we're going to find then, by food we mean nutrients, and these can actually pass through the vessel membrane via diffusion. Same with waste and carbon dioxide. Those can also pass through the tissues back into blood. That way blood can transport those wastes to their appropriate elimination site. Now, what's interesting about the endothelium too is it can create compounds that either can vasodilate or vasoconstrict. We call these the autoregulatory compounds, and these can actually change the vessel diameter. It's involved with inflammation. It's also involved with promoting clot formation if it's injured, and it's going to help to nourish the deeper smooth muscle layer by allowing for the exchange of nutrients across the membrane. So what's interesting too, just if you look at the composition of blood, you're going to find that there's lots of lipids within blood, and we have low density and high density lipids. The high density lipids, or HDLs, they're essentially going to be 50% protein, 20% cholesterol, and pretty low in triglycerides. Now they're high density because they're more tightly packed with protein. Now, as we work our way up this sort of vial of lipids here, we find that we have lower and lower density lipids. So we have our LDLs, which have a little bit less protein, more cholesterol, more triglycerides. Same with the very low density lipids, and then the chylomicrons. Now, what's interesting is actually we absorb lipids in the form of chylomicrons across our digestive wall, and that these are transported through lymph over to the cardiovascular system, which they're eventually transported to the liver, where the liver converts chylomicrons into LDLs. And what these LDLs do is they're basically a transportable form of lipids that have protein receptors that can interact with the cells of your body and allow for these cells to uptake these lipids into the cell for nutrients. Now, what's interesting too is that your body cells can send back these these lipoproteins in the HDL form. And so think of HDLs as being the way that your body cells can communicate with the liver going back the other way. So if we look at the structure of a particular lipoprotein, you find that it's actually in the shape of what we call a micelle. And so a micelle is going to be an outer lipid coat. So you have your phospholipids here. Remember, these are the fatty acid tails in the polar head group. Now the polar head group is going to be hydrophilic, so it's going to interact with water by forming hydrogen bonds. But the fatty acid tails are going to protrude inward towards the center of this particular liposome. Now, in the center of this liposome, what we find then are a lot of lipids, and these lipids can include like cholesterol, other fatty acids, phospholipids can be in here as well, and essentially it's just a way to transport these lipids within a sphere. Now, within the membrane of the sphere, we also have apoproteins, and these apoproteins are involved with helping to stabilize this structure, as well as serving as receptors. That way, these lipoproteins can actually bind with the target cell. That way these target cells can endocytose these within the membrane and then basically take those lipids in for cell energy or support. So if we look at the cycling of these lipids, what we find that is going to start with the intestine. So at the level of the intestine, when you absorb lipids, your intestinal cells package those lipids in what we call chylomicrons. And a chylomicron is essentially just a kind of a loose transportable form of lipids, and we absorb that into lymph, eventually transporting chylomicrons into your bloodstream, where some of these chylomicrons can be taken up by your liver and then converted into very low density lipoproteins. And essentially what happens then is that these very low density lipoproteins then can deliver lipids to adipose and skeletal muscle cells. That way they can use them for energy and support. And then as you start to lose lipids in your body cells, they become like intermediate density and low density lipoproteins. Now, these low density lipoproteins then can be taken up by other cells of your body. We have a scavenger pathway and a receptor dependent pathway. The scavenger pathway is where immune cells can kind of scavenge any kind of loose bits of lipids that may have deposited within the tissues of your body. And then the receptor dependent pathway are where cells of your body can actually sort of bind to these lipoproteins and then take those lipids up into the cell. Now, when this happens, then cells can actually send back lipoproteins in the form of HDL. And these are high density lipoproteins because they're mostly protein, less lipids, and just a little bit of cholesterol. Now, these are transported back towards the liver for recycling. Now, what's interesting about these HDLs is that they are high density, they're more stable, and they can pick up free lipids from your tissues and essentially help to remove those lipids and avoid the immune cells from being activated. And so you want to have more HDLs in your bloodstream because these are actually the ones that help to reverse some of the plaques and other evidence of cardiovascular disease. So in terms of the transportation of these lipids, we said they're chylomicrons when they're absorbed, and then adipose and muscle cells will preferentially take up these lipids most rapidly. And the remaining lipids are now what we call intermediate density lipolipids, and these become LDLs. Now we think of the LDLs as the bad cholesterol, right? You don't want your LDL levels to be too elevated because these are loose and more likely to deposit in your body's tissues, forming plaques, especially like the vessel wall. Now, these LDLs can deliver cholesterol to the liver and other tissues, and these receptors are necessary for internalization. And what's interesting, too, is that some of these LDLs, if they deposit within tissues, they're taken up by scavenger cells or macrophages. In that regard, you get an immune reaction. So it's weird to think that lipids, when they deposit in your tissues abnormally, can actually cause an immune reaction that leads to inflammation and all the associated damage that occurs with inflammation. So remember, the LDLs are low-density lipoproteins, and they're lower density because there's less protein, more cholesterol. Their function is to transport cholesterol from the liver to your body cells. Now, you don't want too many LDLs because they're so low density, they can deposit into your vessel wall and other tissues. And when they're oxidized, they can actually cause an immune reaction that leads to inflammation by those scavenger cells. Now, HDL are the high-density lipoproteins because there's more protein, less cholesterol, and it basically transports cholesterol from cells to the liver. But what's interesting about these HDLs is they actually can pick up excess lipids from your tissues and help to reverse some of the deposition of lipids that may have occurred from LDLs. So if you look at someone's cholesterol levels, they want to have more HDLs and less LDLs as a fraction of cholesterol. So is the following statement true or false? LDL is considered to be good cholesterol. Is that true or false? Well, we know it's false, right? Because LDL is a low-density lipoprotein, has more lipids, less protein, so it's bad because it's more likely to deposit within your tissues. It's looser, lower density. And the HDL is considered to be good cholesterol because it's more protein, less fat, and actually can help to reverse some of the plaques that may have deposited within your vessel walls. So if we look at these plaques, essentially what occurs here in the vessel wall, remember we have our tunica intima, our tunica media, and our tunica externa out here. Now in the tunica intima, we have our simple squamous epithelium, which is actually pretty thin, right? Now deep to that tunica intima, you're going to have your elastic lamina, as well as some supporting connective tissue. Now, what's interesting then with the LDLs is they can diffuse through the vessel wall and then deposit within the vessel wall between the tunica intima and the tunica media. Now, when there's deposition of lipids within the vessel wall, what happens is that this stimulates an immune reaction. because of oxidized lipids, essentially what happens is you get lymphocytes and macrophages that come in and they try to clean up these lipids from the vessel wall itself, because these shouldn't be there and it's considered waste. And if they build up, then your immune cells try to remove them. The problem with this, though, is that through an inflammatory reaction, these macrophages can recruit other lymphocytes to invade the tissue, and it causes the formation of this sort of larger area of inflammation, but also this plaque here. Now, the plaque is going to be contained with, basically foam cells, which are these lipid-laden macrophages, as well as dead tissue from excessive inflammation and oxidized lipids. Now, this necrotic core is the plaque itself, and between the necrotic core and the vessel lumen is what we call the cap. Now, caps can either be thin or thick. If they're thin, then we call this an unstable plaque. If they're thick, then it's a more stable plaque. What we also find, too, is that smooth muscle cells try to migrate into the necrotic core to stabilize this plaque. So if you've had a lot of smooth muscle cells migrate into the plaque, that's actually going to make it more stable. If you find a plaque with less smooth muscle and a thinner cap, this is going to be more of an unstable plaque. And this is bad for two reasons. For one, you don't want this plaque to get so large that it starts to cut off the lumen of the vessel, because it actually can start to grow inward and make the lumen smaller. And then two, if this plaque gets so large, the cap can tear. And if you have exposed collagen in blood, that initiates blood clots, so that these plaques can actually cause blood clots that can plug vessels or cause issues downstream. So if you look at the cross-section of the aorta here, you actually can see the streaking of plaques within the vessel wall. And you can see that in these areas where it looks more smooth. So this is going to be a place in the aorta where you see that there's some plaques that have built up. Now, there's a normal amount of streaking that occurs within blood vessels, but to an excessive degree, then we start calling about how that's called atherosclerotic plaques, and these can actually lead to pretty severe cardiovascular disease. Now, arteriosclerosis is what we refer to as a stiffening of blood vessels. And then atherosclerosis is actually where you get to the accumulation of large amounts of plaques within those blood vessels. Now, what happens here then is that monocytes attach to endothelium, they become macrophages. These macrophages release free radicals that can oxidize these lipids in the attempt to try to break them down. When the macrophages ingest oxidized low-density lipoproteins, they become foam cells, and they're kind of overloaded in terms of their ability to break down these lipids. Now, white blood cells, platelets, and vascular endothelium also release chemicals that promote plaque formation and inflammation. And the problem here is that plaques can block arteries, or they can cause the artery wall to rupture, which can cause blood clots. So the scenario here says a man has several genetic defects in his lipoprotein receptors. For one, his liver lacks LDL receptors, and his muscle cells lack receptors for the apoproteins on chylomicrons. So, if his liver can't uptake LDLs and his muscle cells can't bind to chylomicrons, but his scavenger cells have extra LDL receptors, this question here says, why might he develop atherosclerosis? Well, what's going to happen here is that because of the fact that he can't uptake these lipids, right? His liver can't bring them in very well, his muscle cells can't bring them in very well, he's going to have hyperlipidemia, right? Like excessively high lipid levels in the blood for an extended period of time. And if the scavenger cells have a lot of these LDL receptors, they're going to be overly activated, which means that he's actually going to get the formation of more of these oxidized lipids within his blood vessels, and he's going to form more plaques. So essentially what we're saying here is that due to the disruption of receptor number and location, this can actually promote atherosclerosis through hyperlipidemia, because he can't uptake his lipids, and through an excessive immune reaction that causes these lipids to deposit within the vessel wall. So unstable plaques have thin fibrous caps. Now these are unstable because the plaque can rupture, which can form a clot or a thrombus. Now this may completely block an artery, or the clot can break free, turn into an embolus, and then clog a downstream artery, one that's smaller. Now what the question here says, what immediate threat do unstable plaques present? Is it A, clot formation will increase pressure in the vessel? Is it B, plaque may lead to angina or chest pain? Is it C, clots may break loose and block blood flow to key organs? Or D, all the above constitute immediate threats? Well, the most immediate threat is the fact that these clots can break loose. The previous two, those are more of long-term problems. But if this clot breaks loose and can block downstream organs, it can lead to organ failure. So something that can happen is like you might get a unstable plaque in a coronary vessel that can lead to a blood clot that then breaks off into an embolus. It can plug a smaller coronary vessel and then lead to ischemia of the heart muscle, which can lead to necrosis. And that's going to be, one of the mechanisms of heart attack. Now, it can also affect other organs, like you can get stroke or other organs like the lungs, and really any kind of vascular organ can be affected by these types of, sort of plaque-related clots. Now, other vascular disorders include things like peripheral artery disease, or PAD. So with peripheral artery disease, this occurs in larger arteries, but this is interesting because it's like so much plaque that builds up that it starts to narrow these large arteries, causing blockages. And so peripheral artery disease would occur in larger peripheral arteries, things like the brachiocephalic arteries and like the brachial arteries or the femoral arteries. And so this can lead to decrease in blood flow downstream, but also hypertension because of the fact that these vessels will be abnormally narrowed. There's going to be higher resistance. Now, the thromboangiitis obliterans, also called Brugger disease, is actually a non-atherosclerotic inflammation of the blood vessel wall. So we're saying that you have inflammation of vessel walls, but not due to plaques. It's something else. So this is usually associated with like exposure to different toxins that might deposit within vessel walls, also causing an immune reaction. And that inflammation itself causes the whole vessel to narrow, and this can actually lead to rupture of the vessel, but also increases resistance, which makes it more difficult for blood to flow. Now, it's typically going to affect small, medium-sized arteries and veins, and so you see this commonly like in tobacco users. Now, Raynaud phenomenon is actually associated with rheumatoid arthritis, but what's fascinating here, it's actually an intense vasospasm of some of your peripheral vessels. So like arteries and arterioles in the fingers and toes can vasoconstrict, and then what happens is you get such limited blood flow to the extremities, they get white, they get pallor or cyanosis or bluing, and they get a lack of blood flow to the fingertips, which can actually be very painful. So this one's actually associated with other autoimmune disease as well. Now, the scenario here says a woman complains of pain in her left leg. Her foot is cool and pale, and she reports that it's often red and warm when she's sitting down. The pain occurs when she's walking to church, and the skin on the left leg is shinier than the right leg. And so the question here is, what could have caused all this, and how? Well, if her foot is normally cool and pale when she's walking around, this is going to be due to a decrease in blood flow to that extremity. But what she finds, though, that is when she's sitting down, it ends up being red and warm when she's sitting down. So this would suggest then that her foot is actually being well perfused while sitting, but not well perfused while walking. And so the pain occurs when she's walking to church and her foot's not well perfused. And the skin on her left leg is shinier than the right. And it would be shinier because of maybe some edema or swelling within the tissue. So if we had a guess here, but it's definitely going to be an issue with perfusion. And based on the fact that it's warmer when she's sitting down, she probably has poor arterial perfusion, but decent venous drainage. Because of this sort of disruption of blood flow, it can lead to the fact that it's cool and pale because it's not being well perfused. So the next type of blood vessel injury that can occur are the aneurysms. And aneurysms are a ballooning of a vessel. Now, these typically occur within arteries. It could be large or small arteries. And there's true versus false aneurysms. A true aneurysm is just a ballooning of the vessel wall without tearing the wall itself. So it's almost as if the wall just becomes one large balloon of a vessel. A false aneurysm is where you actually have a tear within the vessel wall, and so that the ballooning that occurs is actually due to an accumulation of blood between like the intima or media and externa. And so that ballooning is actually blood filling up a space between the vessel. And this type of false aneurysm is called a dissecting aneurysm. Now, aneurysms are also classified based on their shape. So if an aneurysm occurs at the juncture of different arteries, we would call this a berry aneurysm. These berry aneurysms are particularly common in the circle of Willis at the base of your brain. But we also have saccular and fusiform aneurysms. So for instance, this would be considered a saccular aneurysm because it sort of forms a large sort of sac-shaped structure. And then fusiform would be where an aneurysm just kind of juts out to one side of the vessel. Like this could be more of a fusiform shape. So the true aneurysms is just a ballooning of the vessel wall without tearing of the wall itself. A false aneurysm is where the vessel wall is torn and blood accumulates between the vessel layers, which is why it's false. And then berry, fusiform, saccular. So remember, the berry aneurysms look like berries, and they occur at the juncture of arteries. Fusiform are going to be more, more mushroom-shaped, and they're going to kind of project out to the side of a vessel. And then saccular aneurysms are just sort of uniformly rounded in a particular length of vessel. Now, dissecting aneurysms are essentially where the vessel wall begins to separate or dissect, and then blood starts to accumulate in the space between the vessel walls. And they can occur. They can also be named for where they occur. So if it's an aortic aneurysm, we're talking about how it's typically going to be like the ascending aorta or the arch of the aorta. They can even be specific too, like the abdominal aortic aneurysm or AAA. These are really common where the aorta splits into the common iliac arteries. It's a AAA or abdominal aortic aneurysm is common there. And we can also get aortic dissections, which is basically where the vessel wall starts to tear. The problem with these aneurysms is they have a high risk of rupture, and when they rupture, you get excessive hemorrhage or clot formation that even if you maybe prevented the hemorrhage, these blood clots can break free and cause problems downstream. Now, when these rupture, because they are big, you typically bleed out so quickly that you lose consciousness within minutes. Now, if it occurs in a smaller vessel, like in the circle of Willis, you might have sort of slower signs and symptoms, things like headache, fatigue, nausea, vomiting, that then can lead into coma. But, with an abdominal aortic aneurysm where it's a large vessel, if this ruptures, it's carrying so much blood, you're going to lose so much blood so quickly that, they lose consciousness within minutes. So in terms of how blood pressure is determined, we knew that the equation for blood pressure is cardiac output times peripheral resistance. And we talked earlier about how cardiac output was just a measure of how much your heart pumps out per minute. And the way you calculate this is heart rate, which is beats per minute, times stroke volume, which is volume of blood per beat. So what happens then is that you get basically blood per minute. And so that's cardiac output. A normal resting cardiac output is about 6 liters, which is about your entire blood volume. Now when we calculate blood pressure, we talk about it in terms of mean arterial pressure. And this mean arterial pressure is just an average of your systolic and diastolic blood pressures. So if you guys remember, we actually talked about how you don't find a lot of time that you spend in systole. You only spend about 1/3 of the time in systole and 2/3 of the time in diastole. So if you want to calculate an average blood pressure, you need to calculate 1/3 systolic pressure plus 2/3 diastolic pressure. And then you divide that to get your average. And that's going to give you a better understanding of what the average blood pressure is because you spend a whole lot more time in diastole, right? 2/3 of the time you're in diastole or rest, whereas 1/3 of the time you're in systole. Now, pulse pressure is just a difference between systolic and diastolic pressures, and this should actually normally be around 40, right? So difference between systolic and diastolic is around 40 or so. Now, if these are close, this is a problem because now we're saying that you don't get the pressure differential. You need a delta P, or difference in pressure for blood to flow, because blood only flows from high to low pressure. So it's important to maintain a pulse pressure, to maintain this difference in blood pressure. Remember, diastolic is relaxation, systolic is contraction. So in terms of blood pressure regulation, it relies on 3 major pathways. It relies on your heart, your blood vessels, and your kidneys. So your heart and your blood vessels are more of the rapid-acting sort of modifiers of blood pressure, right? Now your heart can change blood pressure by increasing cardiac output, and your blood vessels can change blood pressure by altering resistance. Now your kidneys can change blood pressure by altering blood volume, because we learned that blood volume and blood pressure are proportional. So let's say if you had too low of blood pressure, what you can do then is essentially help to increase heart rate or increase stroke volume by increasing heart muscle contractility. Both of these would increase cardiac output, and that's going to increase your blood pressure. Now, we also find, though, that for your blood vessels, there are baroreceptors near the carotid arteries. So right at the place where the common carotids split into external and internal carotids, we have what's called the carotid bodies, and these actually have baroreceptors that measure blood pressure. So if your blood pressure is too high, we get negative feedback that actually causes a decrease in resistance. So you'd actually would have vasodilation that would decrease blood pressure, and that's how you get the negative feedback. So it prevents your blood pressure from getting too high. But if your blood pressure is too low, these baroreceptors can allow for vasoconstriction, and that vasoconstriction can increase blood pressure. Now, with respect to how your kidneys play a role here, we know then that if your cardiac output is too low and your blood pressure is too low, you're going to retain more salt and water, which means you're going to retain more fluid. And if you retain more fluid, you're going to have better venous return, which is going to increase cardiac output. So blood volume and blood pressure are actually proportional, and so that's how the kidneys play a role. Now, we also know the kidneys have a hormonal mechanism too. We talked about how that's the RAAS. And we said that if your blood pressure is too low, you can activate the Renin-Angiotensin-Aldosterone mechanism, where you get the release of renin by the kidneys, which then leads to the activation of angiotensin II. And then angiotensin II can make you thirsty, so you intake more water. It can also vasoconstrict, which increases resistance and increases blood pressure. And it can also act on your brain to make you more thirsty, so you intake more water. But what's really cool too is that angiotensin II has an effect on your adrenal glands, which causes you to release more aldosterone. When you release aldosterone, it causes you to retain more salt. And if you retain more salt, you retain more water. And again, it's going to increase your blood volume. Now, one thing that's not mentioned up here is that angiotensin II also acts on the brain, and it causes your brain to release ADH, or antidiuretic hormone, also called vasopressin, which in itself is a vasoconstrictor, but it also acts on your kidneys to retain more water as well. So with this angiotensin-aldosterone pathway here, we talked about how if your glomerular filtration rate is too slow, the macula densa cells of your kidney tubules can sense this or measure that, and it leads to the release of renin by the granular cells. And so these renin here, that is an enzyme, and it helps to convert angiotensinogen into angiotensin 1. Angiotensin 1 is converted to 2 in your lungs and other peripheral tissues. And we know that angiotensin 2 in itself is a vasoconstrictor, which can increase blood pressure by increasing resistance. But it also acts on the adrenal glands to increase the release of aldosterone, which can help you retain more sodium, which then helps you retain more water. So if you increase your blood volume, then you're going to increase your blood pressure. And there's two more mechanisms up here too. Angiotensin 2 acts on your hypothalamus to make you more thirsty, which can also increase blood volume and blood pressure. And angiotensin 2 acts on your pituitary gland, and it causes the posterior pituitary gland to release antidiuretic hormone, or vasopressin, which also helps you retain more water, but also in itself is a vasoconstrictor. Now, hypertension is just high blood pressure, and we have primary or essential hypertension. It's dependent on things like genetics, race, age, insulin resistance, diet, obesity, and alcohol. And when you think about primary or essential hypertension, this is a direct cause, right? And there's modifiable and non-modifiable risk factors of primary hypertension. For instance, the non-modifiable risk factors would be things like your genetics, your race, your age, maybe even if you have like a genetic disease like type 1 diabetes and you have insulin resistance, like with type 2 diabetes rather, that one's actually modifiable. So like if you have type 2 diabetes and insulin resistance, that's a modifiable risk factor. Diet, obesity, and alcohol are also modifiable, which means you can change them to help to decrease your blood pressure. In fact, to treat blood pressure, like our hypertension, what we find then is that it's recommended to have the DASH diet, which is a diet high in fruits and vegetables and low in processed foods and grains, and also low in meat. But that's also going to help to decrease your blood pressure. Now, secondary hypertension comes from organ failure that in itself leads to hypertension as a result. So an example of like secondary hypertension could be like kidney failure, where you retain so much water because your kidneys are failing that causes you to have hypertension, or excessive release of certain hormones like adrenocortical hormones, like cortisol, or pheochromocytoma, which is a tumor of the adrenal medulla, so you can lead to the release of excessive amounts of epinephrine and norepinephrine, or like structural defects like aortic coarctation, which is actually a narrowing of the aorta, can cause hypertension, or even oral contraceptives. Now, we have hypertensive crisis and urgency and emergency. Now, with hypertensive crisis, we're seeing that someone's systolic blood pressure is over 160 millimeters of mercury. At that point, it's a problem because that's enough pressure to potentially damage your blood vessels. and that we would call urgency, where they want to go seek out care to have their blood pressure lowered. Now, it's considered hypertensive urgency if there's high blood pressure but no evidence of end organ failure. It's considered hypertensive emergency if we have hypertension but evidence of end organ failure, like blood in the kidneys or retinal hemorrhages. If there's evidence that blood vessels have already ruptured and it's causing organ failure, that's what we consider hypertensive emergency. So the discussion here says, how would each of the following affect blood pressure? Vasodilation, we know that decreases resistance, which decreases blood pressure. If you had decreased stretch of baroreceptors, that would actually suggest that your blood pressure is too low. So that would lead to the sympathetic vasoconstrictor response, which can increase blood pressure. We learned earlier how hypoxia in itself is a vasodilator. The point of this is that if your tissues are hypoxic, they can vasodilate to increase blood flow. So hypoxemia would lead to low blood pressure, but higher heart rate to try to get that blood out to your tissues. We know that angiotensin-converting enzyme, or ACE, activates angiotensin II. So if you prevented the formation of angiotensin II, that would prevent your blood pressure from getting any higher. We know that beta blockers, like beta-1 receptors, are on the heart, and beta-1 receptors increase heart rate. So if you block these receptors, then your heart rate would be slower, so your cardiac output would be lowered, your blood pressure would be lower. We also have alpha-2 agonists, and alpha-2 receptors are located on the nerve terminals of sympathetic postganglionic neurons. And what this does, it actually inhibits the release of further norepinephrine through negative feedback. So if you gave someone an alpha-2 agonist, it actually would depress their sympathetic nervous system. And then calcium channel blockers would actually prevent your heart from contracting as strongly, so that your stroke volume would be lower and your cardiac output would be lower, so your blood pressure would also be lower. Another question here says, a patient takes a drug that's a sympathetic agonist. What would be the expectation from this drug? So if you look at these lists here, would it increase or decrease heart rate? Well, we know that the sympathetic nervous system is the fight-flight system, and it relies on nerves and epinephrine and norepinephrine. And so we already know that's going to increase heart rate, fight or flight, right? And the question here then is, would it also increase blood pressure, or would it decrease blood pressure? Well, the answer would be it would increase both heart rate and blood pressure. And the reason being is that you have beta-1 receptors on your heart to increase heart rate, and then we have alpha-1 receptors throughout the body that can also cause vasoconstriction, and that can increase also blood pressure. So in terms of hypertension during pregnancy, we actually have preeclampsia and eclampsia. It's basically hypertension after 20 weeks, and this is a problem in gestationally or during pregnancy, because that high blood pressure can lead to things like proteinuria through kidney damage, can lead to elevated serum creatinine through renal failure, liver enzymes, and decreased platelets, again from poor perfusion of blood vessels, and this can be a life-threatening condition. And it's also damaging to the fetus because it can damage the placenta. Now, you would think about this hypertension during pregnancy as being like a normal mechanism, because you would want to have high enough blood pressure to perfuse the placenta, and that way you can kind of nourish the fetus. But it's considered preeclampsia if it's too much hypertension, like to the point where you're actually seeing organ failure. Now, gestational hypertension is after 20 weeks, but it resolves 12 weeks postpartum. So we're saying that essentially it's where after birth there's still some hypertension, but the hypertension goes away after birth. Chronic hypertension, we're just saying, is like high blood pressure for more than 3 months. And individuals can actually have both of these. Like, they can have chronic hypertension, but then get pregnant and then have preeclampsia on top of that. And that's going to definitely put themselves at risk and their fetus at risk. Now, if we look at the control of blood flow, what we see here then is actually some negative feedback, where if there's pooling of blood in the lower extremities, this actually leads to decreased venous return to the heart, which decreases cardiac output and leads to a decrease in blood pressure. Now, the negative feedback for this then is that through our baroreceptor response, this can actually lead to sympathetic vasoconstriction and an increase in heart rate. Both of these are going to cause an increase in blood pressure, because vasoconstriction leads to an increase in resistance. Cardiac output also increases blood pressure, and that's going to help to reverse the low blood pressure here. And what's also pretty cool too is that to get blood back to our heart, we can actually activate skeletal muscle pumps. So just using your skeletal muscles and squeezing on the nearby veins causes compression of veins, and it can squeeze blood back to your heart more quickly, which again increases cardiac output. And so individuals can actually make a conscious effort to increase their own blood flow to the heart by actually just squeezing their leg muscles, and that can actually force blood back to the heart more quickly. But their body also has normal regulatory unconscious mechanisms that rely on a sympathetic vasoconstriction and heart rate response, which both act to increase blood pressure. Now, we know that veins are pretty thin vessels because they carry blood that's in a pretty low pressure here. Now, what's interesting is that veins have one-way valves, and for the great saphenous vein that goes up the medial aspect of your leg and thigh, there's a lot of valves that kind of work their way up. And this is an important vein because it carries blood from the distal extremities of your lower appendage, and because of standing, what we find is that blood has a tendency, due to gravity, to want to pool towards the feet. Now, over time, it actually can put damage on your valves, and if these valves fail and they become incompetent, then blood just backs up in the veins. Now, what this can lead to then is actually swelling of the veins because they're so full of blood now, and they can engorge with so much blood that they can form what we call these varicosities. And these varicosities are basically areas where blood just is pooling within veins. Now, these aren't just a cosmetic problem. They can also be a problem in terms of venous stasis, because remember, if blood doesn't flow very well, it's at a higher risk for clots. And so if blood's going to clot, then that can form a thrombus, and that thrombus can dislodge into an embolus that can travel up towards the heart and maybe even block vessels in your lungs, which could be life-threatening. So one way to avoid these varicosities is to make sure that you get good venous drainage of your legs. You're not standing too long and causing damage to these valves, and also ensuring that if these varicosities do occur, you get treated pretty quickly. That way they don't get much worse. These can be treated through surgical excision, but there's also like laser surgery as well, where you can use lasers that can essentially burn superficial varicosities. And they're more than just a cosmetic problem. Like, this could be a life-threatening issue due to thrombi and emboli.